and welcome to Friendly Pharmacy 5. Today, we will be speaking with Dr. Preet Khangura. Dr. Preet Khangura is a naturopathic physician who practices in Victoria, British Columbia, Canada at Juniper Family Health Clinic. His clinical focus is heavily fixated on gastrointestinal and autoimmune conditions. Dr. Khangura has become a fixture in the world of SIBO diagnosis, treatment, prevention, and education. He is also a co-founder and co-owner of SIBO Diagnostics, which is Canada's leading SIBO and IBS testing laboratory. Dr. Khangura has pioneered treatment and prevention protocols for SIBO and strives to share his knowledge with other doctors by providing complimentary consultations for doctors using SIBO Diagnostics Laboratory, as well as his in-depth physician-directed continuing education courses. Dr. Khangura obtained his Bachelor of Science in Physics from the University of Victoria and his Doctor of Naturopathic Medicine from the Boucher Institute of Naturopathic Medicine. Dr. Khangura, thank you so much for coming on the channel today.
My pleasure.
If we could just start out, if you could tell us a little bit about your practice. I know that a lot of your practice involves gut health and also addressing autoimmune issues. So as a naturopath, how did you get into this side of your work, and what does your day-to-day look like right now?
Right. So when it comes to us naturopathic doctors, one thing maybe I'll clear up right from the get-go is because different people from different parts of the world are going to be watching this, and a naturopathic doctor kind of means something different depending on where we practice. And
yes.
Here in BC, we are fully regulated, and we are considered primary care physicians, just like your GP family doctor is, in the sense of, we're able to do diagnosis. We're able to send you to the lab for testing. We can prescribe pharmaceutical medications here for the most part, just the same as your family doctor. But of course, on top of that, we have our naturopathic tools of our trade, and that would be herbal medications, clinical nutrition, and other modalities such as acupuncture, even intravenous therapies for certain conditions. And so here in BC, where I practice, I'm able to use all these different tools in my practice. And that's the way I look at medicine, is very integratively. So not this medicine versus this medicine, but putting it all together. And this, in my opinion, works great when it comes to gastrointestinal health and autoimmune conditions, because there really isn't just one way to go about it. There are multiple ways to come at these conditions and illnesses. And so to answer your other question about how I kind of got into those niches in my practice, I always kind of, give my wife credit for even getting into naturopathic medicine, but really actually making my mind always focus on the gut, because back when we were dating many, many years ago in early 20s, she fell very ill with her gastrointestinal system, and she was not getting answers from her family doctor, going to the ER multiple times with significant abdominal pains, and everything came back normal. So no one really thought anything was wrong. And then under the recommendation of one of my close friends' mothers, recommended, you know what, go take her to see a naturopathic doctor. It really helped our daughter. You never know. And so she did see a naturopathic doctor here in town in Victoria. And within 6 months, her life was back. And This was in early 20s, and she was losing her hair, joint pains, and got digestive symptoms. And so it was very worrisome. And through looking at the gut specifically and repairing what was happening at that time for her, really turned her life around. And so some years later, when I graduated university, I was originally going to go into, I have a bachelor's in physics. I was originally going to do a master's in medical physics. And so like radiation treatments and things like that, that was my kind of my goal. But by the time I finished and I saw what happened with my wife, I really started looking into naturopathic medicine and the schooling for that, because of what I've seen with my own two eyes. And so that's how I got into naturopathic medical school. And then I always focused on the gut because, once again, that experience. And so as soon as I started practice, that's where my main focus was. And like any doctor that has a niche, where you put your energy towards, that's where you're going to do best. That's why we call it practice. We practice over and over. And so gastrointestinal disorders became my big focus. And then autoimmunity, which doesn't always have a connection with the GI tract, many times does. And so that's kind of how that branched out into that.
Oh, that's a really interesting story. And I can see why you're so passionate about this, especially if it came from, something that your wife originally suffered with. And so you saw this firsthand, how it really can affect someone. I know that I've seen a lot of patients who have many different kinds of gut issues in general. And there's a lot of information and, research coming out right now about the gut. And there's a lot of talk about the microbiome and the flora of the gut. And I feel like we're just starting to understand a little bit of how important this is. Could you just educate us a little bit on the microbiome? What does that even mean? And where does this bacteria reside in our gut?
Right. Very good questions, because when some people hear microbiome, they have their own idea really what that is. And depending on who's saying it, it really, might have a different definition. But in general, when I say the microbiome, we're talking about our bacterial communities in our intestinal tract. Now, of course, we don't just have bacteria in our GI tract. We can have, normal levels of certain, yeast species like Candida. Now, when that gets a little bit out of balance, that becomes a problem. But generally, it's bacteria, many different species of different bacteria. But when it comes to our microbiome communities, one thing that a lot of us don't think about is where are they supposed to reside, not just what type of bacteria they are. Of course, we want as many beneficial bacteria as possible. And what makes some bacteria beneficial is that some bacteria like Lactobacillus species, Bifido species, some Enterococcus species, just as an example, they have a lot of anti-inflammatory effects for our colon. They ward off dysbiotic, aka, in a sense, bad bacteria and bad yeast from overgrowing. They're kind of our first line of defense against these things. So they're beneficial for a few different reasons. And some bacteria produce certain micronutrients in our gut as well, certain B vitamins and vitamin K and things such as that. So that's what makes some bacteria good for us. But it's also very important to know where they're supposed to reside. And when it comes to our microbiome, we should have at least about 99% of our microbiome living in our colon, aka the large intestine. The small intestines, which is where we do pretty much all of our digestion and most of our absorption of nutrients and medications, and a little bit of water absorption there as well. We are supposed to have a very minute amount of bacteria, even good guys, living in the small intestines, 1% or less. And as we talk today about certain things I kind of have an expertise in, for very good reason, we don't want a lot of bacteria there, even if they're beneficial.
And I see firsthand quite often, how obvious it is that we need to maintain this balance. And a prime example would be someone who's on antibiotics, especially women, and they suffer from a yeast infection. We almost warn them right when we're giving them the antibiotics, listen, you should be taking a probiotic, or, if you come down with these signs or symptoms, this is something to watch out for. And it can really affect a person within a matter of days. And so there's the use of antibiotics that I know that can affect our gut. But has our Western diet or lifestyle choices affected our gut adversely? Or what do you see in practice? Because I really feel like a lot of people are dealing with gut issues, and it seems like it's almost increasingly so.
Yeah, it is. And I think a lot of it stems from potentially a lot of the typical Western diet. So if we focus on that here first. Now, I will say in the last, 10, maybe even 20 years, but especially the last 10, 15 years, there has been a big shift in mainstream living to eat healthier. And, if we look back at the 90s or 80s, I was born in the very early 80s, like that really wasn't the big thing. Like it was very niche to see a health food store talk about fiber intake and things like that. It was all, white flours and, easy snacks for kids, like a microwave and all those things. And in the most recent years, right, and things are better. And the fiber aspect, for example, fiber feeds bacteria. Now, we want the fiber to feed our beneficial bacteria, but unfortunately, even dysbiotic bacteria that live in the human gut will feed on fiber too. So sometimes we're not feeding the right guys all the time. But essentially, the Western diet, probably for the most part, at least I can speak for Canada, probably has more fiber in the diet, even for younger people, than it did, let's say, 20 years ago. So I think from that stance, things are probably getting a little bit better. However, not everyone eats that way. Not everyone focuses on that. But especially when I see my practices, a lot of my patients that have had chronic digestive issues, most of them were, born in the 80s, 70s, maybe 60s. And a lot of them will say, growing up and for early adulthood, their diet wasn't really focused on healthy foods. And so I think from a Western standpoint, there probably was some detriment, and maybe definitely is still today. I mean, there's fast food everywhere, and skip the dishes and all these apps. It's just so much easier to get this stuff, and it's not going to be that conducive to great microbiome. But the other thing we have to think about too is, and I was one of these children growing up in the 80s. I had antibiotics all the time. All the time growing up, and so many of my patients around my age, same story. And for me, it was for good reason. I used to always have significant tonsillitis, and that caused actual breathing issues and things like that. But also because of that, back then, and less was really known about the detriment of antibiotics that aren't needed. I was given antibiotics anytime I had the first sign of a cold. And my parents were worried because I had issues with breathing, with my tonsils would enlarge. And so I definitely got a lot of unneeded antibiotics, and that does that causes a big shift in the microbiome, because of course antibiotics are needed for certain infections, but if you take too much or certain types, you're going to wipe out some good beneficial bacteria in the colon, and that's going to allow potentially dysbiotic bacteria to overgrow, or even yeast and things such as that. And that, especially as a child where you're building your microbiome, the diversity, that can really alter it for going into adulthood.
Mm-hmm, mm-hmm. And I know there's a lot of work that's been done on the use of antimicrobials, and only to use them when needed. But yeah, I can definitely empathize with your experience growing up in the 80s as well. You mentioned something there, dysbiotic bacteria. So I know that in some of your practice, you do see something called dysbiosis. Can you explain to us what is dysbiosis and what is dysbiotic bacteria?
Yeah, so kind of maybe two different things depending on exactly what you're talking about. So this is a good distinction to make. So dysbiotic bacteria can be looked at as bacteria, bad bacteria that's not great for our health, not just intestinal health. There's some dysbiotic bacteria that have been correlated with developing certain autoimmune conditions if you harbor them in the gut for an extended period of time at high growth levels. So these would be bacteria that can cause, inflammation of the intestinal tract. They can create an increase in inflammatory cytokines, not just in the gut, but systemically, create autoimmune cross reactions to occur. One good example that I look out for in patients that have rheumatoid arthritis, which is an autoimmune arthritis, is that, and this research dates back decades now, that many people with rheumatoid arthritis, they found had a high level of Proteus species of bacteria living in their gut. Proteus, when growing out of control at high amounts in the gut, can cause gastrointestinal inflammation, diarrhea, excessive gas, abdominal pains. But what seems to happen in some patients is that the systemic immune system will start to react to the Proteus that is in the GI tract and cross-react and actually create rheumatoid factor antibodies by accident, not just the Proteus antibodies. And so in some rheumatoid arthritis patients, there may be a connection with a certain dysbiotic bacteria living in their GI tract. Now, that's not the truth for every RA patient, of course, but there is a potential there. So that's just one simple example of how the gut can affect our immune system, and how it can affect inflammation systemically. So that would be like a dysbiotic bacteria. Now, a dysbiosis, when I use that term in practice, it could mean too much of that bacteria living in the colon, because that would be an imbalance. And so that's why I look at the term dysbiosis, an imbalance in our gut microbiome. So that could be too much of a bad guy living in the colon, or it could be, and this is what I do a ton in practice, a dysbiosis that is called small intestinal bacterial overgrowth, or SIBO for short, SIBO. That is a dysbiosis in the sense of too many gut bacteria are being allowed to pool and live in the small intestine. So a little bit more than that 1% that should be there ends up remaining there. And it could even be good guys. So in that sense, it's not always dysbiotic or bad bacteria overgrowing in the wrong place. A lot of times it's actually too many good bacteria living in the small intestines. But as we'll get into it, that can lead to a lot of chronic digestive issues.
And you mentioned, you mentioned SIBO there, and I know that you have a laboratory that diagnoses SIBO, right? I think it's called SIBO Diagnostics. And can you explain to us a little bit about how you diagnose SIBO through this laboratory?
Right. So a SIBO, so maybe I'll explain a little bit more about SIBO, then this will make more sense.
Yes, please.
So with SIBO, small intestinal bacterial overgrowth, it's kind of right in the name. It's bacterial overgrowth in the small intestines. And like I just mentioned, it could be too many good bacteria with commensal bacteria, or it might even be some bad dysbiotic bacteria overgrowing along with some good bacteria. But this is a problem because when we have, and this is one reason why we're not supposed to have many bacteria in our small intestines, is that bacteria are gas producers. Right. So when, you know, a person is very flatulent, passing a lot of gas, that's actually our gut bacteria producing that gas, not so much us at all. And burping and belching is usually bacterial fermentation coming up. Now, sometimes carbonation and things like that, we, we'll burp up, but a lot of times it's bacterial fermentation. Most of the time it is. And so our small intestines are not supposed to have a very heavy count or colony count of bacteria because they're called small, not because they're short in length, but because they have a very small diameter. Okay. And they don't have space for bacterial gases. Our large intestine, which is actually much shorter than our small intestines when we stretch them out, has a very large diameter. So it has a housing unit for all those bacterial gases that can occur. So our small intestines don't. So if we develop SIBO, what ends up happening is the food we eat, if it contains bacteria food, which is fiber and certain fermentable sugars, the SIBO will feed on those constituents at an extensive rate in our small intestines and fill up our small intestines with their gases, either hydrogen gas, methane gas, or hydrogen sulfide gas, or maybe all three or two of the three. And this causes our small intestines to balloon out. They have to expand out to fill up with these gases. And this is what, this is what causes the abdominal distension and bloating seen in a lot of IBS patients. And of course, this is either going to stay as trapped gas and maybe cause gas pains, or it's going to release easily and they're going to get a lot of belching or flatulence or both. It can cause heartburn. It can even in some SIBO cases lead to nausea, and it can alter bowel movements, diarrhea, constipation, depending on the type of SIBO that's growing, and the type is based on the gas. And so one thing I should mention, which I forgot to a few minutes ago, is SIBO is one of the most common causes behind IBS. And IBS, for people that don't know, stands for irritable bowel syndrome. And really what it is a label to describe your symptoms, but there has to be a root cause. And SIBO is not always the root cause, but it is one of the most common causes behind IBS because of this mechanism of bacterial fermentation that I just spoke about. Now, there are certain definitions of what IBS is, like Rome 4 criteria and things like that. But that's also not a great way to look at it. A lot of doctors, they've done surveys, don't use the Rome criteria because it doesn't actually have all of the digestive symptoms included in it. So the term IBS gets thrown out a lot, but SIBO is one of those common causes of it. So what our lab does is to diagnose SIBO, it's actually a breath test. And there's a couple different breath tests we offer. We offer the standard 3-hour lactulose Quintron test, and now the brand new 2-hour Trio Smart lactulose breath test, which has been in the United States for the last year and a half, and we finally have it available here. Oh, wow. And both these, right. And so the Quintron test, the one's been around for quite a bit, can test for 2 of the 3 forms of SIBO. It can test for hydrogen and methane producing SIBO. And the new one, Trio Smart, can actually test the third gas, hydrogen sulfide, as well, which the Quintron cannot. And that one can, that test is complete. It can test hydrogen, methane, and hydrogen sulfide SIBO. There is a pretty big price difference between the 2 tests, unfortunately, so not everyone can afford the new test. But when I educate doctors on my courses and everything, I teach how to assess for hydrogen sulfide SIBO if you can't do the expensive test. There are hallmarks to look for in the patient case. But essentially, we provide these breath tests to doctors across Canada to give to the patients to test for the potentially 3 different forms of SIBO. Mm-hmm. And we're also the only Canadian lab provider of the test called IBS Smart. It's a blood test, and this gets into deeper in why we develop SIBO. But this test can determine if you develop SIBO and IBS because of an autoimmune cross reaction that happened after a case of food poisoning.
Wow. Okay. And so I want to make the point that we are not diagnosing anyone here. And
Exactly.
if you're listening to this and you think that you might have SIBO, then that's fine, but you should seek out some medical advice for that. But
Absolutely.
I did want to ask you, are there any red flags or classic symptoms? I know you mentioned flatulence, bloating, that a person could have SIBO, or even experiences they might have had, like I think maybe GI upset or something like that,
Mhm.
that can leave people more predisposed to this?
Right. So to answer that question first, the number one reason why most of us develop SIBO is just one case of food poisoning or traveler's diarrhea,
Mm.
which are both the same thing. We just give them a different label, but it's bacterial gastroenteritis. It's a bacterial infection of the GI tract, potentially Salmonella or Campylobacter jejuni, or, the food poisoning E. coli,
Mhm.
something like that. And this is what the IBS smart blood test can make the connection with, but I won't get into great detail here about it. But essentially, about 1 in 9 of us, when we get a case of food poisoning, will develop IBS within 3 to 6 months afterwards. And these studies have been around for quite some time. And the Mayo Clinic finally just kind of did a meta-analysis of all of them, and they found, yeah, it's about one, because some showed 1 in 5, some showed about 1 in 10. It sounds like consensus is about 1 in 9, and
Mhm.
we pretty much know why that is. About 1 in 9 of us will have an autoimmune cross reaction that occurs in our GI tract that damages a mechanism in our GI tract called the migrating motor complex. And that mechanism is essentially how we do not develop SIBO. It prevents SIBO. And when it becomes damaged and weakened, we have a much higher chance of developing SIBO. So just because someone's had food poisoning, traveler's diarrhea, there's a higher chance this is not going to happen. But about 1 in 9, depending on what study, even 1 in 5, this may happen. They may develop SIBO. So someone with a case of food poisoning, traveler's diarrhea, it potentially could lead to this, but there's other causes of developing SIBO. But then hallmark signs and symptoms are a lot of the digestive symptoms I've already mentioned, such as abdominal bloating after eating, potentially with abdominal pain, but also excessive gas or trapped gas, and potentially diarrhea and or constipation. In some cases, even nausea and heartburn and things like that. So kind of the prototypical, IBS, or what we think of as IBS symptoms. But another key hallmark is, and it sounds funny, but I'll explain in a second, the healthier we eat, the more symptoms we get. That is a hallmark of SIBO, because the healthier we eat typically means eating more healthy, fibrous veggies, fibrous nuts and seeds and beans, fibrous fruits, fibrous grains, so white flour grains. And the reason why there's this connection with eating healthy and having more of those IBS symptoms in SIBO patients is because when you eat healthy, you're eating more of the bacteria food, which is the fiber.
Mhm.
So if you have this overgrowth in small intestines, you're actually feeding the overgrowth more of its food, and it's filling up your intestines with more of their gases.
Okay. So if, say, someone has a severe case of traveler's diarrhea, is there anything they can do to avoid SIBO?
Yeah. So one thing that you can do not so much you can do to prevent. So if
Or
what
just
happens
manage it
is
better? I
to
don't.
manage it right. So the biggest thing is knowing this connection, because if you're one of those patients where the autoimmune cross reaction occurs, where you produce an antibody called antivinculin, if you're one of those 1 in 9 people, that damage and that autoimmune damage to your migrating motor complex is going to happen very soon after the food poisoning, traveler's diarrhea. So you can't really stop it from happening, but if you know this information now going forward, you can then do some preventative, or I shouldn't say preventative, early steps into, getting this dealt with in case you are one of those patients and you might develop SIBO. Because so many of my patients, when I do speak with them, they've had their digestive symptoms from their SIBO for 20, 30 years. And they've always just been told it's IBS and they have to deal with it. And there's ups and downs, or it just gets worse over time. And for some of those patients, it actually was due to SIBO. And if you treat SIBO, you can see that IBS picture go away. So if that type of patient, or even if they've had it for 5 years, knew about this potential connection much earlier in the game, they could have had that diagnosis much earlier, which means it's always easier to treat early on than it is 10, 20, 30 years later. So the biggest thing would be knowing that connection. And if you do start to develop chronic IBS symptoms at the first sign of those daily chronic symptoms, to go get assessed by someone that, maybe treats SIBO, knows about it. That'd be my biggest advice. I mean, if those symptoms don't arise, then you're likely okay.
No, that's really good. Sometimes the practical things that we can just watch for and know where to look, right? If they do happen. Another interesting thing, I was listening to one of your talks recently, and you mentioned a link between rosacea and SIBO. Could you tell us a little bit about that? That was the first I'd heard about that possible connection.
Right. So especially in naturopathic medicine, we do, look at the connections between the skin and the gut very much, not just rosacea, but things like eczema and psoriasis and even, cystic acne and things like that potentially has a connection to the gut. But rosacea and SIBO have a very big connection. There's been studies that showing that there is quite a high percentage of rosacea patients that have SIBO upon testing compared to non-rosacea patients. So that's where it all started. And it's something I do see in practice quite often. Patients with rosacea do have a much higher chance of having chronic IBS symptoms and potentially due to SIBO. And for people that don't know what rosacea is, it's an inflammatory skin condition, usually affects the face, of the cheeks and bridge of the nose, sometimes forehead, sometimes the eyes. So the way the eyes can go red, but usually it's the cheeks that are very inflamed, sometimes itchy, sometimes burning. Sometimes it can affect the chest as well. And a lot of the patients of rosacea do feel like there's a connection with their gut, because certain days they'll eat something, and it's very soon after eating, they feel like the rosacea may flare, but it's really hard for them to pinpoint exactly what's doing it. And so the reason why SIBO is the theory on why SIBO may lead to rosacea, because we see the correlation, but nothing's been proven on the causation of why SIBO leads to it. The theory is that it's connected through intestinal permeability, aka leaky gut syndrome. And leaky gut syndrome, that term is thrown out there a lot. And SIBO is one of the primary causes of potentially developing intestinal permeability of the small intestines, because this dysbiosis SIBO that's in the small intestines is not supposed to be there. And the gut's immune system and systemic immune system will try to react to the bacteria that shouldn't be there. And this can lead to changes in the intestinal lining that can allow intestinal permeability to occur from a few different mechanisms. One of them from zonulin potentially increasing, but there's a few mechanisms. And when we develop intestinal permeability, leaky gut, at the microscopic level, certain things we're going to start to absorb that we shouldn't. And certain proteins, before they're broken down to amino acids, may start to absorb still as polypeptides. And this can create an immune response to things that are leaking through. So one theory is that rosacea, being an inflammatory response, is actually a potential immune system inflammatory response that's showing up as rosacea in patients with intestinal permeability that may be stemming from SIBO.
And so is there evidence that treating someone for SIBO can possibly, in some cases, improve rosacea?
There's some small evidence. They haven't done any large studies on treating SIBO. Will rosacea improve? There is one or two small studies that did show some good changes and some good benefits to rosacea patients. So, but it's not large enough to hang our hat on. So clinically, anecdotally, I do see in my practice, I'd say about, if I had to give a number, roughly about 50% of my rosacea and SIBO, so patients have both conditions, SIBO and rosacea, about 50% of them, their rosacea will start to improve as we get rid of the SIBO and their digestion improves. Some patients, it's minor improvements in the rosacea, some patients it's significant or anywhere in between. Then about 25% of my patients, their digestion gets better first, and then in the next 3 to 6 months, the rosacea starts to improve as probably the gut starts to have the ability to heal again. And once again, minor improvements to significant. And then I say about a quarter of my rosacea and SIBO patients, we can, if we do deal with the GI tract and digestion improves, the rosacea does not tend to improve as time goes by. So in those cases, maybe there's still a connection, the gut just didn't heal well enough, or maybe in that case, there was no connection.
That's very interesting. And what about anemia? Do you see how does the interplay between the gut and anemia?
This is a big one because it gets overlooked as a cause of chronic anemia, iron deficiency. And sometimes it's not just full-blown anemia, it could just be very low ferritin, but hemoglobin's still okay, and RBC is okay. But SIBO can be a cause of iron deficiency or make iron deficiency worse. And the reason being is that bacteria use iron for their own virulency, just like we do. And if you now have bacteria overgrowing in your small intestines where you're supposed to absorb your iron from, this bacteria can now use a lot of the iron that's coming in through your food or supplementation before you have a chance to absorb it. So you think you're getting certain levels of iron through eating certain foods or taking your iron supplement, but the SIBO, the bacteria, may be using some of that iron and not allowing you to absorb it like you normally would. And this can actually lead to anemia in some patients, or it can make it worse faster. And so there is definitely a connection between SIBO and potentially iron deficiency, and also SIBO and B12 deficiency, because bacteria also use B12, and so they can also use some B12 that comes in through the oral route before you have a chance to absorb it.
Yeah, and so many people do suffer from anemia, and sometimes we know why, and it's good to investigate why, but sometimes there's really no reason. And I see especially a lot of women who suffer, and also it's true, people can take supplements for quite some time and not see very much of a response. So I guess that would be a red flag. If you're taking iron and you're not seeing any improvement, it's good to look further into what could be the cause.
Especially if that patient also has chronic digestive issues, because then it'd be like, okay, there's more reason to think something at the gut level maybe has something to do with the iron malabsorption. And it's not just SIBO, it's celiac disease, very significant iron deficiency can occur because of the flattening of the villi in small intestine. So for a different reason. But even if it's not celiac, because that's one thing a lot of doctors will rule out someone's unexplained iron deficiency is let's test for celiac. And then they test that and it's like, okay, the patient's not celiac, and then they kind of stop looking at the gut. But if those digestive symptoms are there, definitely you want to look at things potentially as such as SIBO for unresolving anemia.
And something else I wanted to ask you about was the subject of biofilms. So I've heard of biofilms before when we talk about like a medical prosthetic, and then a biofilm developing over that, and then that being treated maybe with antibiotics. But I know, and I've read that there is more information coming out about biofilms in our gut and bacteria forming these biofilms. So could you tell us a bit about what is a biofilm? How does this form? I heard that you need more than one type of bacteria for a biofilm or something. And how can this affect treatment?
Right. So bacterial biofilm production is probably the biggest roadblock behind successful SIBO treatments, and can even be a roadblock behind treating infections, like actual. And that's one thing I should maybe clear up too, because people hear bacteria and SIBO. SIBO is not an infection; it's more of an imbalance, a dysbiosis. Now you still use antimicrobials and potentially antibiotics to get rid of it, but it's not an infection. But even chronic infections can be held back from resolving if there's biofilm being produced by the bacteria colonies. But biofilm is just natural. It's a natural thing that bacteria do when they cohabitate. So you mentioned that you need more than one bacteria, and that's true. And so that's why some infections, biofilm's not a big problem, because it might just be a single bacteria causing that infection. But when it comes to the gut and SIBO, when someone develops SIBO, it is never just one species of bacteria overgrowing. It's always multiple species. So biofilm will be produced. They cohabitate and they start to produce this microscopic film that is held together by metalloid links, which are metal-like constituents, and it holds the biofilm together. And they produce this to adhere their colonies to a surface. So potentially, for example, the intestinal lining. And then it's to protect themselves from the environment, your gut's immune system, or antimicrobials, antibiotics. And also, if you Google image bacterial biofilm, you see these kind of little animations where they show the biofilm build up, and then the biofilm kind of disperses out so the colony can go attach somewhere else. And so it's a way to propagate their communities. And so maybe throughout the small intestinal tract in the SIBO case. And so it can inhibit treatments from working well, because what happens is if someone has biofilm being produced in their intestinal tract and and they have SIBO, and you give the patient antimicrobials, some of the bacteria is going to come out of the biofilm to feed when that patient feeds. So only some of the SIBO is going to be exposed to the antimicrobial, but the rest will not be. And so you need something that can open up the biofilm, biofilm disruptors and things like that. Now, so not all SIBO cases need anything significant like that. Some need significant biofilm disruption for the treatment to work. Now, a good example of everyday biofilm too, because a lot of this does sound kind of strange to people, but when they think about it this way, it's like, oh yeah, that makes sense, is that if you don't brush your teeth for 24 hours, you get that film on your teeth.
Right.
And that's bacterial biofilm. We call it plaque, but it is bacterial biofilm production. Does not take long for you to feel it after stopping the brushing of your teeth. So you can see how quick it forms. And so just imagine the gut where it continues to build and build as the colonies build and grow, and we're not actively brushing that biofilm off in the gut. And so it's something that is very important, not just with SIBO cases, but even other other type of infections. But it's something that definitely needs to be focused on. And one reason why a lot of people, their SIBO is tough to treat or is not resolving when it could be if that's being dealt with.
Okay. I should have warned you all to take notes because Dr. Khangura is full of so much information.
Right. I sometimes can't stop myself. Right?
No, it's excellent. It's excellent. It's really good information. You mentioned earlier Zonulin, and I did want to touch on that. Could you tell us, I know Zonulin is something a lot of people are talking about right now. What is Zonulin? What is the role of Zonulin in the picture of our gut here?
Right. So zonulin is a inflammatory kind of modulator of the gut. And essentially what it is it's a gatekeeper molecule for the intestinal lining. So our intestinal lining is very thin at the microscopic level, but it's held together, each intestinal cell, very tightly by tight junctions that would be right here, holding those intestinal cells together. And when our intestinal tract, our small intestinal tract is nice and healthy, and those tight junctions are nice and tight, only things that are supposed to absorb into our bloodstream will, like protein broken down to amino acids, those amino acids now can absorb, for example. So zonulin, if it's increased, what happens is that tells those tight junctions to open up. And it's like a door that opens. So it's not so much the intestinal tract kind of like, actually opening up like this, and becoming like porous, and if we visualize that, it's more like this little door that just kind of opens. And when it opens, what happens is things can leak through into our systemic system. And so that's where, undigested proteins can leak through, certain toxic waste from bacteria, whatever it is, or certain things we're eating that normally wouldn't leak through would leak through. And this is intestinal permeability. So zonulin increasing is a very common cause of leaky gut syndrome. In celiac patients, zonulin is shown to be extremely high. And so that's one reason why celiac patients, before they realize they're celiac and they're eating gluten, have very inflamed intestinal tracts, very, and sometimes very serious, skin conditions that are linked to celiac disease because of the significant leaky gut, because zonulin is very high in celiac patients. When you take the gluten out, the zonulin will come down and the gut can hopefully heal. But even things like dysbiosis, like SIBO, or fungal growth and things like that can increase zonulin. Not the same level as celiac, but it can do it, and it can start to open up those tight junctions, and you start to get leaky gut syndrome. And the one reason why our body does this, like why would our body do this? Like why do we produce zonulin? Like if it just hurts us, the biggest reason is that the body thinks it needs to send troops, systemic immune system cells, into the gut. So it starts to open up the tight junctions to send like white blood cells in. And that could be because SIBO's there and the gut's immune system is not dealing with it. So it's starting to increase zonulin to try to get the systemic immune system components there. In celiac disease, it's a big part of the autoimmune response that happens in the presence of gluten. The body thinks it needs to go and kill gluten right away in that gut because of an autoimmune reaction to it. And so that's why zonulin is very much increased there. So it's kind of it's in a sense, poor decision by the body to do it. But that's why it happens in some people.
Very interesting. And I also wanted to ask you about stomach acid. So I know that there are so many people that are prescribed acid reducers, and sometimes long-term. And this can be for good reason. This can be for ulcers or different issues. But the stomach acid is very important for digestion. And so my concern is maybe the overprescribing of these medications, but don't make any changes to your medications. I just wanted to know from your standpoint, What do you see in your patients as to people who might have low stomach acid and have had stomach acid for quite a while? Could this leave them predisposed to intestinal issues?
Right. So low stomach acid definitely can lead to some just direct digestive issues, especially with proteins. So most of our food is broken down in our small intestines by enzymes that are released by the pancreas, including proteins. But the first step to protein digestion happens in stomach acid. So we need sufficient amount of stomach acid to unfold protein at the microscopic level one time. Therefore, when it enters the small intestines, it'll be broken down properly. So a lot of patients with low stomach acid, they'll notice that eating heavy amounts of protein causes them issue or causes them digestive issues. And that could be potentially one sign of it. And then also you may not break down your protein properly then, and maybe not get the amount of amino acids and protein you think you're getting. And so just from a protein digestion standpoint, it can be an issue. But for many people, what chronically low stomach acid can lead to is actually, acid reflux and heartburn or GERD in general. So a lot of people have heard this, low stomach acid can lead to heartburn, but it doesn't make sense, right? In some people's minds, because low stomach acid, but heartburn, it makes no sense. Well, one reason, why people believe that low stomach acid can lead to chronic heartburn and the need of things like PPI medications or over-the-counter antacids is because when stomach acid becomes too low, when someone eats, the stomach acid rises, but it never rises now to the threshold to tell the lower esophageal sphincter to close properly. And that sphincter is supposed to close to protect our esophagus from acid. And so if it never reaches that threshold, then it doesn't close well or doesn't stay closed very well. And so as the stomach starts to churn, even though there's lower stomach acid, the acid can start to actually still come up. And so you can actually develop chronic, GERD and reflux. And so that's one detriment long term. And then, of course, a lot of those patients end up going on PPIs and antacids because you got to protect the esophagus. There's a time and place for doing this. And so it definitely makes sense. But there are a couple of things that can actually help re-strengthen that lower esophageal sphincter because it becomes weak over time as well. So when the stomach acid stays low long term, that sphincter stops getting exercise of opening and closing. So when stomach acid does get really high and it does reach the threshold, it still doesn't close well for a lot of people. So they really need to stay on antacids. But there are a couple things that have been proven to help re-strengthen the LES. So that's what I typically do in practice, is work on that as opposed to just suppressing acid forever. Time and place for that though. But once we get that LES hopefully working better, we can hopefully maybe then wean the patient off the antacids if possible. But now when it comes to SIBO, a lot of people read about, low stomach acid can lead to SIBO because more bacteria then survives, like bacteria goes in orally. That's
what I was wondering about.
Yeah. Now the thing with that is, it's never going to be the number one cause of SIBO, because even if too much bacteria, even regular bacteria, gets into the small intestines, if that patient's migrating motor complex, that thing I mentioned a few minutes ago, that can get damaged from food poisoning, that's the sweeping action of our small intestines that kicks in every 3 hours. It sweeps excess bacteria out of our small intestines into our large intestine every 3 hours. So even if extra bacteria get in, or we take probiotics that are a bunch of extra bacteria, the reason why they're not going to stay in the small intestines is the MMC kicks in and sweeps them into the large intestine where it's supposed to go. So long as that mechanism is working properly, low stomach acid should never lead to SIBO. But if someone has SIBO or is developing SIBO because that MMC is weak and bacteria doesn't get flushed out very well, then low stomach acid theoretically may allow more bacteria into the small intestines, and it may help speed up the process of developing SIBO. But it's not as important as maybe some people put out there as low stomach acid means you're going to develop SIBO. That definitely, I don't agree with that.
Yeah, no, that's interesting. I'm glad I asked that, because I was wondering about that, because we do see a lot of people on these proton pump inhibitors, different acid reducers, and whether there was a link there. So it's good to hear about that from you. You did mention probiotics there as well, Preet, and there are so many probiotics out there, and people are taking them like, I don't know, even for myself, it's hard to know. We look for a high potency probiotic. We know that it's good for someone who's been on antibiotics to be on a probiotic. I always recommend it. Are all probiotics the same, or are there any red flags? Like if someone is taking a probiotic and they notice that, maybe they're having trouble with it, or can you shed some light on this? I know this is a huge topic, but a few key points maybe for us.
Right. Yeah. So a couple of maybe I'll keep the key points to maybe related to SIBO, IBS,
Sure.
and that.
Sure.
So probiotics, like you said, there's a million of them out there. What's what and what's the important thing to know about it. So if we just ignore SIBO and IBS for a second here, and we just look at, well, what type of probiotics should we take if we decide to take a probiotic? Well, we want to make sure the probiotic we're taking are HMF forms of bacteria. So HMF stands for human microflora. So not just that they're lactobacillus species or bifido species, but they're ones actually meant to reside in the human GI tract, because those are the ones that have the higher chance of potentially seeding in our colon and flourishing from there. Now, they don't always, and there's been a lot of research that's come out showing probiotics maybe don't do as much as we think they do. Or you're taking probiotics with antibiotics, does it prevent things like C. diff, infections, or yeast infections? And there's not a lot of great evidence showing that it does a good job of that. Now, that could be for various reasons, like maybe it's not the right type of probiotic. Maybe if patients are taking high dose of HMF lines, it would start to prevent these things, and maybe they got to do studies specifically with those strains, because there definitely are good HMF type of probiotics out there that can really help with certain conditions and help with gut health. But so that's one thing to think about. But the other thing to think about is, if for a SIBO patient, is if they've developed SIBO, that usually means their migrating motor complex, the sweeping action of their small intestines, is not sweeping bacteria out of their small intestines as well as it should. So if you put a bunch of bacteria in orally, even if they're good guys, they're still gas producers. And if those bacteria put in are not all forced into large intestine, then they can actually pool in the small intestine and actually create more SIBO. So one thing I see in practice a lot, and a lot of other doctors do as well, is SIBO patients do not do well with probiotics. And so before the patient even knows what the word SIBO is, if I've never brought it up, never heard about it, I'll always ask the question, have you tried probiotics for your digestive issues, and how'd it go? A lot of these patients will actually state, I feel much worse when I take a probiotic. And now it doesn't guarantee they have SIBO, because it could be feeling worse for a few reasons. But it makes sense why a SIBO patient, by taking probiotics, can actually make them feel worse. Or I'll ask them, probiotic fermented foods like sauerkraut, kimchi, kombucha, kefir, those four especially, what happens if you eat those? And same answer for a lot of SIBO patients is, I do not do well when I eat those. I get more gas, more bloating, or if I do for a week, I'm way worse the week after. And a lot of patients, they say, I took a probiotic and I felt no different, because probiotics, if someone's developed IBS, even if it's not due to SIBO, but especially if it's due to SIBO, probiotics aren't really going to fix the IBS in most cases. But there's a time and place. Like, patients have to do very broad spectrum, heavy dose antibiotics. And you want to do probiotics at least afterwards, in case you can replenish some of those good bacteria, even if the antibiotics didn't lead to an opportunistic infection. It's still probably a good idea to do. It's just certain patients, probiotics may be a good thing, may not be. And when I say not a good thing, it's not detrimental in most cases, nothing serious. It's just they might notice things like digestive symptoms may get worse.
No, and it's good to have those insights, because it's a big world of probiotics out there. And I know that you mentioned there's a lot of new information coming out about probiotics, and there's actually someone coming on the channel who's a pharmacist doing research in this. And because we really need some guidance on this, and because they're also expensive, right? People are, well,
they are, and I don't want to downplay the importance of probiotics. I kind of made it sound like I just did, but because they are good bacteria, there's a reason why we have them. They're extremely important for our colon health. It's just taking pill versions, are they really going to make a clinical difference? And that's the key. Now, and maybe this person you're having on, maybe it's you're going to dive into this, or maybe not, but certain FMT treatments that have been, fecal transplant treatments have shown really great benefit for certain people. Now, here in Canada, it's only approved for very specific things, but in other parts of the world, they're using FMT treatments for many other issues and intestinal issues, including IBD, inflammatory bowel disease. And so not just to treat maybe C. diff, things like that. But and that's a different, those are true human microflora bacteria, because it's FMT, it's fecal transplant. So that's that's a little bit of evidence right there. You need the right type of lactobacillus, you need the right type of bifido species, and then within those realms of species, there's many different types, and so it is very complicated. And the doctors and researchers that are doing like the FMT trials and research, they'll be the first to admit is that we're just scratching the surface on what each bacteria may or may not do and how we can deliver it to the colon.
No, I'm glad that you pointed that out. That's important. And just in closing, Dr. Khangura, you had mentioned leaky gut, and leaky gut is kind of like this thing that everyone's talking about these days. And, there's 1,000 remedies, repair your leaky gut. And, a lot of them I don't think are evidence-based. But do you have any advice for us? So if someone wants to just try to maintain a healthy gut, in general, if they don't feel like they really have any issues, but are there any things, any guidance, lifestyle choices, or anything like that you would recommend?
Yeah, so just for the general person whose digestions may be fine, but they want to do more preventative stuff, and they just want to keep their gut as healthy as possible, because the gut everything connection is very much there.
It is.
There are there's some things you can do. So food is medicine. This is a great way to look at keeping the gut healthy. There are certain foods that are pro-inflammatory. There's certain foods that are anti-inflammatory. So if we want to keep the gut as healthy as possible, we want to keep gut inflammation as low as possible, just like we want systemic inflammation as low as possible. And you can do this through, certain diet changes. So there are certain anti-inflammatory type of diets patients can do, and definitely under the, guidance of a practitioner that can help them through it. But there's different levels of this, but, there are certain anti-inflammatory diets that I've seen make a big difference in people's health, when it comes to potentially leaky gut connected illnesses or conditions like skin conditions, or brain fog, quote unquote, or sleep issues, or joint inflammation, whatever it may be. And so food is medicine is one way I look at it, is just keeping the inflammation in the gut as low as possible by not putting pro-inflammatory things in. And that'd be through certain, it doesn't mean you have to be eating 100% anti-inflammatory. That's very, very hard and difficult to do. But if you are right now eating 70% pro-inflammatory foods, 30% anti-inflammatory, if you swap that, that's a huge difference. Or even if you bring that to 50-50, that's going to make a big difference. That's the first step. And then maybe get it to 60-40. Then you're going to, probably do your gut some good. And so watching other things too that you intake, like there's, certain preservatives in foods, and we're learning more and more about these type of things and what can potentially cause gut damage and all that. But looking at the diet, I think, is the simplest way. And then these other therapies for certain conditions can come in if those conditions develop.
And probably generally, I would guess, getting away from manufactured foods, eating whole foods, that kind of thing.
Exactly. Yeah.
Well, you have given us an incredible amount of information. I'm sure some people have to watch this more than once to really absorb all of this. But thank you, Dr. Khangura, so much for joining us today and for giving us a little bit of your knowledge and talking to us about SIBO. And I'll put all of the links to Dr. Khangura's work and his lab in the description of this video if you would like any more information. So thank you so much, Dr. Khangura. Take care.
No problem. Thank you.
Well, I hope you found that helpful. Dr. Khangura certainly has a lot of incredible insights and experience in this area. Let me know in the comments what you thought of the interview, and if you have any questions about gut health. Maybe we'll have Dr. Khangura on the show again sometime soon. I hope this helped. Take care and stay healthy. Bye-bye.